Welcome to Monday Morning Panic. Now, this is your super fast, hyper-focused review for that upcoming nursing exam. Let's just jump right in.
Okay, first up, cirrhosis. We need to understand how it looks different in the early versus late stages.
Right. And one of the huge things you see with liver dysfunction is that profound third spacing.
Yeah.
Fluid just leaking out where it shouldn't.
Exactly, leading to major edema.
And specifically associates that abdominal edema.
Yeah.
We'll track it with an increased abdominal girth, and rapid weight gain. It's really significant.
It is. And the labs, well, they tell a big part of the story. You'll see decreased serum protein and definitely decreased serum albumin. The liver just isn't making them.
Makes sense.
And conversely, you get those elevated ALP, AST, and GGT. Those are your critical liver function indicators showing damage. Plus, elevated bilirubin.
Which leads to those classic signs.
Yeah, the clay-colored feces and tea-colored urine, and of course, jaundice. Very visible.
Okay, and something else critical, that decrease in clotting factors. This means a much increased risk of bleeding.
Huge risk.
Patients might bruise easily, sure, but you're really watching for hematemesis, vomiting blood, and melena, those dark, tarry stools.
Or hematuria, bright red blood, all critical findings.
Definitely. What about electrolytes?
You often see increased sodium and decreased potassium, but a really major concern is increased ammonia.
Because it's neurotoxic.
Exactly. It leads straight to encephalopathy. That's where you get the confusion, sometimes aggression. It's a key thing to monitor.
And with blood backing up through that damaged liver, you get portal hypertension.
Right. And that pressure causes those dangerous esophageal varices, enlarged veins in the esophagus, super high bleeding risk.
And it can also cause splenomegaly, right? An enlarged spleen.
Yep. Other common things you'll see, intense itching, that's pruritus.
Oh, right.
And spider angiomas, those little spider-like vessels on the skin. Also palmar erythema, which is red in palms.
And that distinctive breath odor.
That sweet, musty odor, yeah. Vitor hepaticus.
Patients might also struggle with breathing, respiratory distress, dyspnea, maybe hyperventilation.
Often due to the pressure from ascites, absolutely.
So medication-wise, for that increased ammonia.
Lactulose. It works by drawing ammonia into the GI tract, the goal. You're aiming for 3 to 5 bowel movements per day. That tells you it's effectively removing the ammonia.
Got it. And for the fluid shifts?
Spironolactone is common. It's potassium sparing, but big caution here, watch out for salt substitutes.
Why that?
Many contain potassium, and that could push the patient into hyperkalemia. Very dangerous.
Okay, good point. And for the portal pressure?
Beta blockers. Things like metoprolol, propranolol, they help decrease that portal pressure and, importantly, prevent bleeding from those varices.
All right, quick lab summary then. Key liver indicators.
Your ALT, AST, and GGT, always check those.
And confirming again, serum protein and serum albumin are usually down.
Right, and bilirubin is up.
Clotting factors are decreased, so expect that prothrombin time, the PT, to be prolonged. More bleeding risk.
And definitely monitor serum ammonia for encephalopathy and keep a close eye on electrolytes like NE+ and K+.
Okay, priority interventions. For respiratory distress from ascites.
First thing, elevate the head of the bed. Simple but effective.
And monitor fluid status closely.
Daily weights and measuring abdominal girth. Every day. Non-negotiable.
Okay. Promote rest, help with nutrition, and for that itching, the pruritus.
Recommend they file nails short. Scratching is a real risk for skin breakdown and bleeding.
Good tip. What about severe fluid buildup?
Paracentesis can be done to remove that third space fluid, but critical caution, drain it slowly. Too fast can cause hypervolemic shock.
Okay. Dietary management.
Sodium restriction, definitely. Food restriction too, often. But here's an important update. Protein restriction is generally avoided now.
Oh, really?
Yeah, current recommendations are actually 1 to 1.5 grams per kilogram per day. They need protein for healing.
Gotcha. And the absolute most critical lifestyle change?
Complete cessation of alcohol, period.
Patient education points.
Emphasize, no scratching, no straining, like during bowel movements, think varices.
Definitely avoid NSAIDs or anticoagulants because of the bleeding risk.
Right. And stress good skin and oral hygiene.
Skincare is vital overall, right? Due to edema and breakdown risk.
Absolutely. And consistently monitor mental status for any signs of hepatic encephalopathy.
Okay, shifting gears now to diabetes. Diagnostics, emergencies, care.
For diagnostic testing in labs, let's start with fasting glucose. 101/125 is pre-diabetes, 126 or higher. That's diagnostic for diabetes.
And normal is typically, what, 70-100?
Usually, yeah. Then there's the A1C, or glycosylated hemoglobin. That gives you the picture over the last 2-3 months.
And the goal there is generally lower than 7%.
Correct. And a random glucose over 200, especially with symptoms, can diagnose type 1.
Okay, diabetic emergencies. First, the simple one. Hypoglycemia, blood glucose too low.
Right. Then there's DKA, diabetic ketoacidosis, more common in type 1. Key things to look for: ketones, Kussmaul respirations, that deep, rapid breathing.
And that fruity breath odor. Very distinct.
Exactly. Now, contrast that with HHS, hyperosmolar hyperglycemic state, more common in type 2.
And the big difference from DKA?
The absence of ketosis and acidosis. That's key. Instead, you see severe dehydration, really high glucose, typically over 600.
Wow.
Yeah, plus altered mental status, hypotension, weakness. It's serious dehydration.
Okay, interventions for hypoglycemia. If the patient is unconscious.
Immediate glucagon intramuscularly or dextrose IV.
And if they're conscious.
Fast-acting carbohydrates. Glucose tabs, gel, juice, regular soda, something quit.
And then follow up once they're above 70.
Yes, critically important. Follow with a snack that has both carbs and protein to keep them stable.
Good point. And maybe a snack before bed to prevent overnight lows.
Often a good strategy, yes.
All right, treatment for HHS and DKA. What's paramount?
Rehydration therapy. It is extremely important. Usually start with normal saline.
And for the high glucose.
IV regular insulin. That's your first-line defense. Allows for careful titration.
And you need to watch electrolytes closely during this.
Absolutely. Potassium levels especially need close monitoring, as they can shift rapidly with insulin and fluids.
And, like any emergency, ABCs first. Ensure a patent airway.
Always. Particularly with altered mental status or those Kussmaul respirations.
What about sick day rules? If a diabetic patient gets ill,
They should continue insulin as usual, sometimes even more, because illness stresses the body and raises glucose.
keep drinking fluids.
Yes, lots of liquids, even sugary ones if they can't eat, to prevent dehydration.
And the exercise rule.
Crucial. Do not exercise if blood glucose is over 250 or if ketones are present in the urine. It can actually make things worse.
Okay. Let's touch on related meds. Glipizide.
That's a sulfonylurea. It works by stimulating the pancreas's beta cells to release more insulin.
And metformin.
Primarily works by inhibiting the liver from producing too much glucose. And remember, that critical point must be held before procedures with contrast dye. Risk of lactic acidosis.
Very important. And just to reiterate for emergencies.
IV regular insulin is the go-to for rapidly lowering glucose in DKA and HHS.
Okay, let's move to the thyroid. Hypo versus hyper, and their emergencies.
For hyperthyroidism, the mnemonic is everything is sped up. Think hot, agitated.
So excessive increase in heart rate tachycardia, increased temperature, lots of anxiety, irritability, insomnia.
Exactly. Trembling, sweating a lot, major heat intolerance. Often weight loss despite increased appetite and frequent bowel movements.
And visually, you might see a goiter.
Very common. And that eye issue, exophthalmos, the bulging eyes, very characteristic.
Okay, so hypothyroidism is the opposite then. Everything is slowed down, low, and slow.
Precisely. Patients feel cold, gain weight easily, experience profound fatigue and lethargy.
So clinically, you'd see bradycardia, slow heart rate, maybe hypothermia, decreased blood pressure.
Yep. Also dry, flaky skin, a puffy face, maybe drooping eyelids, and definitely constipation.
And a key safety point.
They are very sensitive to sedatives and opioids. Metabolism is slowed, so these drugs hang around longer. Use extreme caution.
Got it. Now, the hyperemergency. Thyroid storm.
Life-threatening. Super high fevers, dangerous dysrhythmias, neurological impairment. A true crisis.
Interventions.
Need to control the heart rate with beta blockers, like atenolol. Monitor vitals frequently. Expect continuous cardiac monitoring. And you have to aggressively control body temperature.
Other meds for storm.
Thyroid hormone antagonists, methimazole, propylthuracil, PTU, they block hormone production.
Okay, and the hypoemergency. Myxedema coma.
Also life-threatening. Patient becomes extremely hypothermic, unconscious, respiratory drive plummets.
So the highest priority intervention.
Maintaining airway patency with ventilatory support, absolutely critical.
And again, that sensitivity issue.
Yes, be acutely aware of their extreme sensitivity to sedatives, opioids, and anesthetic agents. And, of course, keep the patient warm.
Education for ongoing management.
Emphasize taking meds as prescribed. It's usually lifelong replacement therapy, especially levothyroxine, Synthroid for hypo.
And how should levothyroxine be taken?
Critical point. On an empty stomach, at least 30-60 minutes before breakfast. Best absorption that way. Also, advise them not to switch brands without talking to their provider. Bioavailability can differ.
Okay. Hypo patients should also avoid the cold.
Yes, dress warmly and eat high-fiber, low-sodium, low-calorie foods to help with constipation and weight.
And for hyperthyroidism, diet advice.
Encourage small, frequent, high-calorie, high-protein, low-fiber meals to meet that high metabolic demand.
Quick med review again. Thyroid storm meds.
Propylthuracil, PTU, and methimazole, tapazole, the antagonist.
Hypo replacement.
Levothyroxine, empty stomach, 30-60 minutes before breakfast. Don't switch brands.
And beta blockers for storm.
Metoprolol and propranolol to control that heart rate and other hypersymptoms.
All right, let's tackle Parkinson's. What's the absolute top priority?
Safety and preventing complications, that's number one.
And a big part of that is?
Aspiration precautions. Dysphagia is common, so elevate the head of the bed during meals, use thickened liquids, prevent aspiration pneumonia.
And the other major safety risks.
Fall precautions, that shuffling gait, the postural instability, they're a high fall risk. Home safety is key. Remove rugs, cords, ensure good footwear.
Let's talk pathophysiology briefly. What's happening?
It's caused by the death of dopamine-producing neurons in a part of the brain called the substantia nigra.
Leading to a dopamine deficiency.
Exactly. And that deficiency causes the classic motor symptoms: rigidity, tremors, and bradykinesia, that's slow movement. You also see Lewy bodies, protein clumps in the neurons.
Medication education, the main one.
Levodopa, carbidopa, brand name Sinemet, it's considered the most effective medication, replaces dopamine.
But he has its challenges.
Yes. Patients can experience a wearing-off effect between doses, and long-term use can lead to dyskinesias, those involuntary movements, like grimacing or head bobbing.
In a key dietary interaction.
Critically important, avoid taking this medication with high-protein meals. Protein interferes with its absorption. Big teaching point.
Other side effects.
Things like GI distress, hypotension, syncope, which again all contribute to that fall risk.
So nursing interventions for safety boil down to?
Implementing those aspiration precautions and fall precautions consistently.
And encourage therapy.
Yes, PTOT are vital for mobility. Plus, ensuring adequate nutrition and providing emotional support. It's a tough diagnosis.
Okay, let's talk seizures. Nursing care. Before, during, after.
Before a seizure, think preparation. Implement seizure precautions. That means padded side rails ready, suction and oxygen at the bedside, and have IV access established if possible.
Okay, during a seizure, what are the absolute priorities?
Protect the patient from injury, especially their head. Guide them safely to the floor if they're standing or sitting. Turn the patient onto their side, critical for maintaining an open airway and preventing aspiration.
And the don't.
Do not restrain them, and do not put anything in their mouth. Absolutely not. And crucially, time the seizure from start to finish.
Got it. After a seizure, in the postictal phase.
Maintain that side-lying position. Provide oxygen if needed. They'll likely be confused, very tired, want to sleep. So reorient them gently. Keep monitoring consciousness and O2 sats.
So quick recap on precautions and safety equipment needed.
Padded side rails, suction, oxygen at bedside, IV access. Be prepared.
What about a tonic-clonic seizure specifically?
That involves loss of consciousness and those violent muscle contractions. Tonic phase is body stiffening. Clonic phase is the jerking.
And potential complications during it.
The tongue may be chewed, and the patient can become incontinent.
Related medication. Phenytoin. Dilantin. Key points.
It's an anticonvulsant. Classic side effect: gingival hyperplasia, gum overgrowth. So meticulous oral hygiene is crucial.
And it has a tricky therapeutic level.
Yes, a very narrow therapeutic range, 10-20 micrograms per milliliter. Requires frequent blood draws, and if giving it IV.
Must be given slowly and only with normal saline. Mixing it with anything else or giving it too fast risks crystallization and serious cardiovascular issues, even collapse.
Critical points to remember for phenytoin.
All right, let's shift to pediatrics. Orthopedic and neuromuscular. First, clubfoot, Talipes equinovarus.
Key thing here: treatment begins as soon as it's discovered, ideally right after birth. Diagnosis is usually visual. You see the deformed talus bone, shortened Achilles.
And family education is huge.
Absolutely vital. It's a long haul. They need to learn stretching exercises, understand the importance of wearing the special shoes and braces full-time for 3 months, then usually at night for up to 3 years.
Early signs are that obvious club-like foot.
Right. Later, if not treated, you'd see gait problems, balance issues, stress changes on the outside of the foot.
Okay, next, hip dysplasia. Developmental dysplasia of the hip.
A key sign to look for is limited abduction of the affected hip. You can't move the leg outward as far. And remember, it might not be caught right at birth, so ongoing checks are important.
Education if a Pavlik harness is used.
Parents must know how to manage it, check for tightness. The rule is 2 finger widths of space under the straps, prevents skin issues and nerve problems.
And if they need surgery and a hip spica cath?
They'll need a special car seat. And for keeping the cast clean, teach the double diapering technique. Really helps keep that area clean and dry.
Okay, muscular dystrophy, usually Duchenne's. Diagnostic labs.
Creatinine kinase, CK levels, they are extremely elevated in the early stages because of muscle breakdown. EMG shows abnormal muscle activity. Muscle biopsy, DNA testing confirm it.
General nursing care focuses.
Implementing aspiration precautions and respiratory precautions as those muscles weaken over time. Encourage range of motion exercises.
Diet recommendations.
Usually low calorie, high protein, high fiber. Helps manage weight and potential constipation. And allow for frequent rest periods, cluster activities to conserve energy.
Early symptoms. Anything unique?
Yes, that enlargement of the calf. It looks muscular, but it's actually due to fat infiltration. That's an early unique sign.
Other early signs.
Gait issues, wide stance, waddling, frequent falling, difficulty getting up. That's the Gower sign. Weakness usually starts showing up between 3 to 7 years old.
And late stages.
Sadly, they eventually lose the ability to walk, become bedbound. You see dyspnea, shortness of breath as cardiac and respiratory muscles get involved.
Medication.
Corticosteroids like prednisone, used long-term to help muscle strength, pulmonary function, slow things down.
Yeah. Long-term steroid risks.
Yeah, risk of bone density loss, so they need calcium and vitamin D supplementation.
Okay, final topic. Multiple sclerosis, MS. Autoimmune challenges.
The pathophysiology here is a chronic, progressive autoimmune disease. The immune system attacked and destroys the myelin sheath covering nerve fibers in the CNS.
So it disrupts nerve signals.
Exactly. Demyelination messes up the information flow. Over time, the axons themselves can degenerate, leading to permanent damage.
Who's most at risk? Risk factors.
Primarily affects women, typically between 20 and 50 years old. Other factors include Northern European ancestry, smoking, pregnancy, severe stress or fatigue. Even infections or trauma can trigger it.
Early signs versus late signs.
Early signs can be subtle, come and go, often vision problems, optic neuritis, blurry vision, diplopia, double vision, also numbness, tingling, fatigue, weakness, headaches.
And late signs, more severe.
Yes, you see spasticity, muscle tightness, often in the legs, severe fatigue, bowel and bladder issues, dysphagia, difficulty swallowing, cognitive impairment, eventually paralysis.
Other common symptoms later on.
Lack of coordination, balance problems, unsteady gait, tremors, dizziness, pain. It's quite variable.
Education is key for management, right?
Yeah.
What should we teach?
Teach them to avoid triggers. Big ones are extreme temperature changes, both heat and cold. Also stress or fatigue, infections, trauma. These can all cause flare-ups.
Or what about exercise?
Encourage light exercise only. Short bursts, frequent rest periods. Avoid overexertion. Emphasize sticking to their medication regimen strictly.
And checking before taking OTC meds.
Yes, always consult their provider first. And teach them the signs of infection, when to seek care immediately.
Medication management, a common one.
Interferon beta 1A. It's a disease-modifying drug to reduce relapse frequency and severity, but it has a very common side effect.
Which is?
Flu-like symptoms. Fever, chills, muscle aches, very common after injection.
How can patients manage that?
Taking acetaminophen or ibuprofen beforehand can help. Taking the shot at night lets them sleep through some of it. And teach proper injection technique, site rotation.
What about for acute flare-ups, exacerbations?
High-dose corticosteroids like methylprednisolone given IV reduces the inflammation rapidly.
And for home management, what's the top priority again?
Priority intervention is safety and fall risk prevention, always. The lack of coordination, unsteady gait, spasticity put them at high risk.
So practical steps.
Implement fall precautions. Call lights in reach, night lights, remove rugs and trip hazards, use bed rails appropriately. Safety first.
Wow, okay. We just covered a massive amount of critical information. Remember, this Monday morning panic review is all about hitting those key points right before your exam.
Yeah, and as you go into that test, try to think beyond just memorizing facts. Think about how all these pieces fit together, how they impact patient outcomes, and what your specific role is in making that outcome better.
Exactly. Good luck on your test, everyone. We'll see you next time on The Deep Dive.